Right. Hello, everybody. We're going to give you a few minutes to kind of get everything checked in. We're going to have you take some time to push down and look at the video, or maybe it'll say use computer audio. You should be muted and your camera should be off, but you should be able to see and hear us on this end. Okay. Give it just a few more, maybe another minute, 12:01 or so. There is a chat and a Q&A section at the bottom. So if you have any questions during the seminar at all, you can put them in either spot. We will be able to see and answer them at the end, most likely. All right. And it is 12:01, so we're going to go ahead and get started. My name is Alicia Heading. I'm a physical therapist at Renue Physical Therapy in Midland. And I've been here since 2013, so we've been here for a couple years now. I did my training at Central Michigan University and have been practicing in Mid-Michigan ever since at a couple different locations, but doing primarily outpatient since 2008. So, but here in Midland since 2013.
And my name is Crystal Parker. I'm also a physical therapist. I work here at Renue. And I graduated from the University of Michigan in 2008 as well. Been practicing predominantly in the outpatient world in the Bay City area, and then have been in Midland the last few months, but I reside in Midland for the last 10 years.
So again, if you are just logging on, we're gonna go ahead and get started with our presentation. If you have any questions, you can enter them in the Q&A box in the bottom, or you can put them in the chat, and we will have them be answered near the end of the entire presentation. There's a question and answer section there. Okay, so a little bit of history and background on vestibular disorders. 1 in 5 people have a vestibular disorder, so that's an estimated 20% of the general population that's affected. At least half of the overall United States population is affected by balance or some type of vestibular disorder at some point in their life. And approximately 15 out of every 1,000 individuals will end up going to seek treatment or find some type of care from their family physician each year due to complaints of vertigo or dizziness or other kinds of imbalance. Half of those individuals are typically over the age of 65, and they most often develop what we call positional vertigo. So, when we speak about dizziness and imbalance and vertigo, a lot of times this does result in falls. And that can be a very scary thing, especially as we age. It's a scary fact, but 50% of elderly falls are a result of some type of vestibular disorder. So in about 15% of those, we can't always recognize the exact cause. It could be a lot of other comorbidities, such as poor mobility, weakness, loss of sensation in the feet due to neuropathy. So there's a lot of components that go into the whole type of imbalance, but vestibular disorders definitely play a large part. Let's see. We're going to spend a little bit of time talking about the anatomy of the ear. This is where all of our balance is kind of housed. Everything that we rely on, our sensory organs, everything to do with balance is controlled by reflexes between the inner ear, which is our vestibular system, the eyes for vision, and the sense of touch, so proprioception, so where we feel our body in space, the sensation of our feet hitting the ground, all of those things contribute to our balance overall. So I'm going to use my mouse. You should see the little cursor here. You can see here, obviously we have the outside of the ear, the external ear. The outer ear consists of just basically the auricle, and then we have our ear canal. We're going to go down a little bit into the middle ear, which is right in here in this green section. And in there we have all air. It's pretty much the eardrum, which also known as a tympanic membrane, and these bones in here that contribute to our hearing, and they help with sound and sound transfer. We're going to take a little, pointing with my finger, sorry, you guys can't see me do that. We're going to take a little deeper look into the inner ear here. So I'm going to flip to another side. So you're going to see this section right here become larger. And in the inner ear, this is where the sensory organs for hearing and balance actually exist, and they are housed within the temporal bone for protection. So they're not actually in the ear or near the ear canal, they are housed within the bone itself. This section is mainly made up of fluid. The inner ear, it's also called the labyrinth. So if you've heard of that, maybe like labyrinthitis or something to do with that, that's also referring to the inner ear. And it contains two main sensory organ structures. One is the cochlea, which is involved in hearing, and I'll point over that, it's right here. So it transforms sound vibrations into a nerve impulse that then sends neural images or neural messages to our brain, telling us what we're hearing, what the sound is, those kinds of things. And then we have the semicircular canals and another portion called a saccule and a utricle. These aren't, I mean, we're gonna go a little bit into depth into those, but you don't have to know those words, but just know that the semicircular canals play a huge part in what we call positional vertigo. So we are gonna take a look into that here in our next couple slides too. I want you also to notice that because this area here, we have a nerve here, we also have an eustachian tube that comes down. Because this inner ear area is so closely connected to the nerves and the pathways into the cerebrospinal fluid regions, that if you have an infection or if you've been on antibiotics for something, or if you have what we call inflammation in the nerve or vestibular neuritis, those things, those other diagnoses or problems can actually lead to balance issues as well, because all of it is so closely connected to our vestibular system. So any disruption in this section of the ear can lead to balance dysfunction. So getting into those three semicircular canals, and I'll show you a larger picture so that it makes a little bit more sense. We have three semicircular canals. There's an anterior, a posterior, and a horizontal, so that we can detect all different angles of motion. These canals are sensitive to head movement, and they measure angular motion, acceleration and deceleration. These are also going to work together in pairs. So obviously we have those in both sides. So when the right side is working on one, say it's a right anterior, the left anterior is going to work, and the left posterior will help kind of decrease. So it's a shift. The otolithic organs are down here in this section here, and it's the utricle and the saccule. And those actually help us detect more linear motion. There's this little section right here called an ampulla. This is gonna be important because that's where when we get to, when we talk about the crystals that everyone likes to talk about, the crystals in our ear, that's where that part of the crystals kind of are housed, and where the macula, what we call it, where those will transfer. And we have similar receptors throughout the semicircular canal. So we'll talk about that a little bit. But here, these canals detect head motion. They also coordinate with eye movements when we rotate our head or have any type of angular acceleration or deceleration in our bodies, or heads, if you're just moving your head. So if you're nodding or shaking your head, no. They work together in pairs, like I said before. So the right anterior and the left posterior are going to work together to provide us a sense of equilibrium. So if we're turning our head this way, this side is going to let our body know that we're turning to the left, shifting forward anteriorly, and the posterior side over here in this canal is going to let us know that we're shifting to the left, but it's going to help accelerate and decelerate, so excite and inhibit, so that we always have a sense of stability. These little sections down here again, where everything kind of comes into and connects, that plays a large part in us understanding where our positional neutral is, or where our head tilt in space and the position of our head against gravity. So those also help with our posture, because if something is abnormal, or if we have a dysfunction down here in this part of the inner ear, you're gonna feel a little off center. You're not gonna know necessarily where your center of gravity is or your head position in space. So if we look inside of this section here and in through the canals, we would see something that looks a little bit like this. So here we have, in what's called the macula, otoliths, which are the little crystals that people will refer to inside our inner ear. And they're actually calcium carbonate crystals, and they're called otoconia. So what happens is these crystals float right on top of this membrane here. And as our head is tilted or undergoes any type of acceleration or deceleration, these little crystals will shift. And so if you look at this picture here, they're sitting very stable at the top, and all these little hair-like follicles are standing upright, and the head is in neutral. When we shift the head forward, let's say, you can see that those crystals disrupt that membrane, causing those hair-like follicles to shift forward. That then sends impulses and signals down into these lower parts of the hair cell here and into the nerves. So that's what gives those impulses of movement. So when people say one of your crystals is lodged or stuck or out of place, when you're sitting like this, what you'll find is instead of all of those hair-like follicles being upright, you have a crystal stuck somewhere that is actually stimulating one of those hair-like fibers to be in a different position. That gives you a sense of movement when you're really not moving. Down here at the bottom, you can also see again, there's a lot of nerve branches that come into these sections of the inner ear. So as we said before, any type of inflammation in one of the nerves could lead to a disruption in that vestibular sensation and how those hair cells or how those synapses are connecting between the inner ear and our brain, sending messages that may or may not be true. So when we look at vertigo, there can be several different reasons for vertigo or dizziness or imbalance. And we look at peripheral symptoms versus central symptoms. So they do look very, very similar, which is why we go through a series of tests as physical therapists to kind of rule out what it is we're actually looking at and what symptoms you're actually having. So when we look at peripheral symptoms, we see severe nausea, mild imbalance, common hearing loss, bouncing, that's what oscillopsia is, bouncing of like vision because nothing kind of sits level in your field of sight. Some neurologic symptoms and rapid compensation. So that means you're trying to adjust your vision when your imbalance is off, not always successful. So an example of a peripheral type of vertigo would be related to positional vertigo, where every time you get up or change positions, lay down, turn, you get that sensation of the room spinning. You don't feel a sense of stability. Maybe you feel like you're on a boat. Another thing would be inner ear issues such as Meniere's disease or labyrinthitis. And when we compare that to central symptoms, you're gonna have some nausea, you're gonna have severe imbalance, difficulty standing upright, sitting upright at any time. Some hearing loss, we do see rare cases of it. A lot of what we call the oscillopsia, where your environment is bouncing, however, you're not moving. Some neurologic symptoms. So you might have loss of sight. What have you maybe seen, Crystal, as far as neurologic symptoms that might correlate with a loss of movement? And it'll make sense when I give you some examples of diagnoses we see. And then also slow compensation. You're not very good at recovering from these sensations of imbalance. Your body can't quite figure out how to compensate. And some examples of a central relationship vertigo would be of a bleed in the brain, a brain stem tumor or a tumor somewhere in the brain, a central nervous system tumor, a severe infection, head trauma, such as a head injury, or even multiple sclerosis. When we see symptoms that present similar to the central list, we have to ensure that all other diagnoses have been ruled out, such as a stroke or tumors, and we may often refer you back to your primary care physician if those are the symptoms that we're seeing, because that is something that needs to be addressed quickly. So as we said before, something else that plays a huge part in our balance is our vision. So we have a reflex in our body. It's called the vestibulo-ocular reflex. This, we shorten it with VOR. This enables us to have clear, steady vision during eye movements and head movement at the same time. So when the head is moving, the VOR, that reflex, is activated. And that VOR input, that vestibular input, is used to hold the image that you're looking at. So if you're looking at the screen right now and you turn your head, you should still be able to maintain your gaze on the screen, even though your head moved. And that's that vestibular ocular reflex working. It's the ability for us to keep looking and focus When the semicircular canal signals are engaged, that also signals how fast the head is moving, and it then works together with that VOR to respond back. And the semicircular canals in our vestibular system will operate at an equal velocity in the opposite direction of the VOR. So the semicircular canals and the VOR work together equally at the same velocity so that you can maintain that gaze while your eyes stay, head moves. So that is part of what we would do. We would check that VOR reflex, that vestibular ocular reflex, during our physical therapy examination. Some other things we do under what we call the oculomotor exam to assess for peripheral and central lesions or vertigo vestibular issues are if you have nystagmus. And nystagmus, we have a video on this later, is where you have little jumping of the eyes. It can be either in one direction or it can have a rotational component. You might see the eyes kind of turning. And somebody that has this will check the ability for your eyes to follow an object called smooth pursuit through a certain distance to make sure that you can, and I'm sure all of you have had doctors do this before, to see that the eyes and the ears and the brain, all of those reflexes are working together properly. And then we do some other things where we ask you to hold your gaze on something. We may check how quickly or rapidly your eyes move when you're switching back and forth between objects. And we also do a maneuver where we turn your head manually and watch your eyes and see how they respond to make sure that your vision can stay focused. We use all of these tests to check the inner ear and your ability to maintain the stability of images in your line of sight while you and we position your head in different directions. This is typically our window to the inner ear to see what kind of dysfunction is happening and where we need to continue to further our tests to rule out different diagnoses.
Okay, so just going to start with some of the most common diagnoses that would relate to vertigo symptoms that we see here in physical therapy. So the first one is BPPV, which is the positional vertigo with the crystals. So this is a condition with a change in head position that causes a sudden sensation of spinning. So again, most likely it's the crystals that break loose in the canals of the inner ear and touch those sensitive nerve, excuse me, those nerve endings, excuse me. Next one is vestibular neuritis, which is inflammation of the vestibular nerve. And Lish had kind of talked about, you know, how close that nerve sits to that, to the inner ear. So it runs through the inner ear and sends a message to the brain that helps control balance. So a common diagnosis would be an acoustic neuroma or a tumor of the vestibular nerve. Then labyrinthitis, which is the inner ear infection. Meniere's disease. This causes repeat episodes of dizziness. There's usually ringing in the ears. Sorry, no, that's okay. Go up one more thing. Here we go. I'm sorry. So it usually has ringing in the ears and progressively low frequency hearing loss. So Meniere's disease is usually caused by a change in the volume of the fluid inside the inner ear. And although the reason for this change is unknown, scientists suspect that it may be linked to a loud noise, a viral infection, or biologic factors inside the ear itself. With this diagnosis, this isn't a diagnosis that here in therapy we can say, yes, you do or don't have Meniere's. There's usually other testing through an audiologist or another neurological doctor that actually makes that diagnosis. The next one would be a bilateral vestibular loss. So only about 28 out of every 100,000 people in the US will experience this. In many instances, the bilateral vestibulopathy is due to exposure of ototoxic medications, usually in about 35%, and in about 10% it can be caused by an infection such as meningitis. Cervicogenic dizziness is something that I've started to see a little bit more with. So people with cervicogenic dizziness tend to complain of dizziness that is worse during head movements or after maintaining a position for any length of time. So the dizziness usually occurs after the neck pain and may be accompanied by a headache. And then often the dizziness will decrease when the pain of the neck decreases. And these symptoms of dizziness usually last minutes to hours and often occur as a result of a whiplash or a head trauma. And the last one is migraines. So people who experience migraines may have episodes of vertigo or other types of dizziness, even when they're not having the severe headache. So such vertigo episodes can last minutes to hours and may be associated with a headache as well, and have some of that light or noise sensitivity that usually triggers the migraines itself. All right, so I'm going to spend a little bit more time on the BPPV, the benign proximal positional vertigo. I never get that right. This is probably, I think, the most common that we see in the outpatient world. It's probably my favorite because the research shows after the first treatment, you're about 80% better. So it's not necessarily the most fun to have done or have to go through the procedure, but you notice a very quick recovery, and it's a very easy fix. 1 or 2 treatments and it's usually pretty much healed. So just a little bit about it. It occurs spontaneously in most cases, so about 50 to 70%. It can be very common after a head trauma, so 7 to 17%. Can be very common after an inner ear infection. It is, again, the most prevalent peripheral vestibular disorder, and the posterior canal is the most common form. So I always try to explain, you know, we have an anterior canal, a posterior canal, and there's a horizontal. So there's 3 canals, and you have those on both sides. So kind of like Lish had said, the anterior on the right kind of works in conjunction with posterior on the left. So when you're moving your head, those crystals are floating in that canal. So that's usually an easy differential diagnosis for us to be able to rule in or rule out BPPV is if head position changes your symptoms at all, but it should recover fairly quickly. So there are 2 types of BPPV, cupulolithiasis and canalolithiasis. With the cupulolithiasis, the otoconia, which are those crystals from the utricle, are displaced into the canal and it attaches to the cupula. So there is immediate onset of vertigo. So once you move your head, your symptoms are very, very quick. And the nystagmus can last as long as the vertigo. So again, the nystagmus is that irregular subconscious movement of the eye. And so with the cupulolithiasis, the symptoms last a little bit longer, so it's a little bit more miserable. Where with the canalolithiasis, the otoconia is floating in the fluid that's in that canal. So it's not adhered to anything. So there's usually a delay in the onset. And so then there's an increase of symptoms, and then those symptoms usually decrease. So they usually never last more than 60 seconds, where with the cupulolithiasis, it's usually over a minute that their symptoms and nystagmus are present. So with these 2 theories, there are 2 different procedures or treatments that we use, because with the cupulolithiasis, again, that otoconia is actually adhered and attached. So unfortunately, it's a little bit more of a quick and forceful maneuver to treat it. So this picture, this is probably the most common that we use, the CMOT maneuver. And so this picture shows from the left to right, it shows you the eyes on the left, and then that next little section shows you the semicircular canal. So if the crystal is that little white ball up at the top, so then what it's showing you is as you move, I'm pointing at that, that's not gonna work. As you see that guy move from one position to the next, it's moving that crystal out of the canal. When it comes to BPPV, our goal is to get the crystal out of the canal and put it in that little blue part, that little sac that's at the center where all of those canals attach. And then within 24 hours, your body is supposed to reabsorb that crystal and hopefully not have it again if that was the only one you had. So again, this one is a little bit more forceful. You come from one direction and you have to quickly come forward to the opposite side to help loosen that crystal and clear it out of the canal. With canalolithiasis, the most common, again, is in the posterior canal, 92%. And we test the anterior and posterior canal the same way with the Dix HALLPIKE. And we test the horizontal canal with the barbecue roll. And this next picture is just a quick little video to show you what nystagmus looks like. Again, this is a subconscious irregular, what we call a twitch of the eye, and it can be multi-directional.
Never mind the woman with the very funny goggles on. We don't put these on you. Those, but what you'll see when the video goes to focus on the eyes only, that's what we'll be looking for, and that's what the nystagmus would look like in someone who had these symptoms, some of these symptoms. So we're gonna go right into here. You'll start to see the eye jump and move a little bit, and you'll see there's that uncontrollable movement inward, and you see a little bit of rotation with that in that eye too. So we look for all of it. We want to know which way the eye is moving. We want to know which way the eye is rotating. Is it rotating up? Is it rotating down? So when we do that test, we ask people to keep their eyes open, even though it's really hard to do that. That again allows us to figure out, is it a cupulo or is it a canal lithiasis issue? So those indicators help us kind of work through our decision tree to figure out which treatment's going to be best for you.
You'll see a lot of ENTs that use the Forenso goggles, and they use those because it occludes your vision. You can't focus on anything. And when you have any form of a vestibular dysfunction that you've had for any length of time, you subconsciously learn that if you focus on something, it helps override your symptoms. And so the problem becomes, we could test you and you could test negative because your body has learned to compensate and focus on something. So that's usually why they'll use the goggles, is to help you not be able to do that. And it's a better, I guess, diagnosis without that happening. So this picture is the Dix HALLPIKE. So this is, again, what we would do to test the anterior or posterior canals. There are certain head positions. So it's important that through our PT evaluation, we have screened the cervical spine and the neck to make sure you have specific, it's roughly 45 degrees of rotation to one side and approximately 30 degrees of extension. If you don't have those, this test, we might have to alter how we do it. We can alter the table. There's different things that we can do, but ideally we need to have your head in a certain position to stimulate that canal to see if that triggers the response with a crystal. So this is showing, and later on we're going to walk through this, but this is just kind of showing you, this is the test. And so the first step of the treatment is ultimately the test. So most of the times, once we put somebody in that position to test them, we'll go right into this, which is the treatment. And the reason for that is, most of the times when we put you in that position, you don't want us to put you there again because it stimulates those symptoms again. And it's miserable, but it should last, less than 30 seconds. And again, with time, it does get better. But this shows rotating the head one direction, then the other direction, and then we kind of roll you. There's a 4-step process that we do to help clear whether it be the anterior or the posterior canal for the BPPV. Then when it comes to the horizontal canal, because again, it sits at a different plane than the anterior and posterior, we use what's called the barbecue roll. So that's what this picture is. So this again would be to treat if you had crystal that was inside that canal. That's what I was going to say. The nystagmus, the reason we want to know if it's beating to the right or beating to the left, what direction, that tells us which side and if it's the anterior or posterior canal. So because we want to try to treat
right away
the proper canal versus wasting the time. So that's why this helps lead us to which treatment we would use, because that test would have helped differentiate that by the eye movement. So if you were to come to therapy again for a vestibular examination, it's billed just like regular physical therapy is. So it's not like it's when you're looking at insurance or anything like that to see if it's covered. It's any physical therapy, is covered through this. So we do an upper and lower body screen. Then we do the oculomotor exam that Lish had talked about, looking at different eye movements. Again, we can't see in the inner ear, so we have to use eye movement to tell us. We then will go into a lot of balance testing. We'll look at your gait, which is how you walk, maybe put different obstacles in front of you and see how you do, because we also want to see your depth perception, and visually what you're seeing relaying to the brain and telling you how to respond to that. So just a couple different tests. The other big one that we use is putting you on foam, because that tells us if you have proprioception problems. Again, proprioception is you knowing where you are in space. So if you're diabetic and you have neuropathies, you're probably going to have issues with that. As we get older, we become very visual dependent. And so if we do any test and we close your eyes, you really have a hard time maintaining your balance. But if your other systems are working, it shouldn't be as challenging. So through therapy, there's different things we can do to help improve how your body responds on firm ground, uneven ground, eyes open, eyes closed, all those things. So when it comes to treatment for any type of vestibular, there's different theories out there. So when it comes to balance, you have your vestibular, your vision, and your proprioception, and you need all three of those to work together. So I tell people your inner ear is just like a muscle. It needs to be stimulated through exercise. So as we get older, we become more rigid, and we just don't move as much, and we don't clean, and we don't do all of these things. So your vestibular system starts to function at a lower capacity. So then when you go to get up or you go to quickly turn your head, it can stimulate those symptoms because you've almost made that system go dormant. So there's a lot of exercises that we can do. So with what we call habituation exercises, it's a long-term reduction of the response to the triggering stimulus. So what that means is if you bend over to tie your shoe and it bothers you pretty regularly, we will actually have you do that repetitively, because what that does is that decreases the neural response to that movement. So those repeated movements to that stimulus over time will not cause the same sensation. And then with adaptation, those are long-term changes of the neuronal response.
We did have one question come in. We'll take a little bit because it relates to what we're talking about now to answer it. And it says, is there a way I can prevent an attack if I feel it coming on? And this is kind of why we do these certain types of treatments, the habituation, the adaptation, is because that's what we in turn hope to teach you so that you can learn how to manage your symptoms long term. So yes, we try to find out and educate you on what triggers your episodes, what positions or what movements are creating the symptoms of vertigo. And if you can get into some of these habituation exercises and do these regularly, or if you can figure out which positions seem to bother you the most, we might even tell you those are something that you might want to avoid. That's something we can't habituate that. We can't get your body to respond to that stimulus the way we want to. So that might be something you would like to avoid. Again, everybody is a little different. So all these exercises and all these theories work differently for each person. So, I mean, we can answer a couple more questions that are similar to that too. But if you sense an attack coming on and you've already been through one of our treatments where we teach you one of those maneuvers, the EPLEY maneuver, the CMOT maneuver, or the barbecue roll, you've been through your therapy and you're familiar with those, we often tell people if you feel an attack coming on, do that treatment. We educate you, we give you handouts on how to do these at home, because the research shows that the more often you do these exercises, these treatment exercises, the quicker your symptoms resolve. So the better the outcome. And so we will often tell people, if you start to feel an attack of vertigo coming on, do that treatment we did with you and do it until the symptoms go away. Not all day long, but there's a certain frequency. We usually do the treatments 3 times a day. And so we would ask you to follow that same protocol.
And if you're the person that hasn't seen the doctor yet to have the diagnosis and you start to notice symptoms, the sooner you can get into the doctor and get to us, the better. Mm-hmm. Because what's going to happen is your body is going to start to compensate for that, and your vestibular system is going to only become weaker and weaker over time, versus if we can get in there and get it moving faster, you don't have to worry about all those compensations.
Yeah. And a lot of times we will have the question, people will call and they'll say, I have vertigo, I went to my doctor gave me medication. Don't take the medication before you come to therapy. That medication does a very good job at what it's supposed to be used for. It minimizes your symptoms, it reduces your symptoms. But sadly, as miserable as it is, the symptoms are what lead us in the right direction when it comes to us diagnosing what side or what issue you actually have. So again, the sooner you get to the doctor or to get the referral to come to physical therapy, I know some insurances may not even require you to go to your doctor first, but the sooner you seek treatment and go through that process, the better your outcomes are going to be. And if you do go to the doctor and they do prescribe you medicine, call us first and get your appointment set up right away, we can usually get you in fairly quickly so that you don't have to take the medication. Now, if you do need to take the medication because you can't get into us until another day, we ask that the day you are scheduled to see us, that you try to avoid taking that medication so that we can understand fully what your symptoms are. You will need a driver when you come to those appointments because we are stimulating the vestibular system. We know you will be dizzy. You may even get some nausea and some other unpleasant symptoms. So we always suggest that you don't come alone and that you have a driver with you.
I guess one thing about that medication is a suppressant. And so what happens is if you're on that long term, it's going to actually increase your fall risk because it decreases your response time. So just being cautious, again, it's just one of those medications that if you don't have to take long term, it's better for you all around. Just a little bit about therapy treatment frequencies. It can vary anywhere between 1 to 3 times per week. Again, with the BPPV, usually 1 or 2 treatments is all you need. Now, if you've had it for years and years and you've compensated, it might be longer because then we need to work on, again, a slower functioning vestibular system. If you're not one that has BPPV but has vertigo, and it's more just because it's a neuritis or it's a, over the years compensation type of a thing, it can take longer. It didn't just come on overnight, so it's going to take a longer time to be able to work at it, but it's something that you have to do on a daily basis with the treatments. This video is, again, testing for the BPPV, but what you'll see at the bottom of the screen, that little red crystal is actually going to move through that semicircular canal as she moves her head. So this is just a picture or a video that's going to show the importance of relation of head position to gravity to help stimulate that system and get that crystal cleared.
This video is about 2 minutes long. And so just so that we can show you how things flow. So after this video, we'll actually do a demonstration to show you how quickly this process actually happens since the video
Normally, only with head movement does fluid within the inner ear also move, informing the brain that a head turn occurred. However, should a crystal called an otolith gets displaced into the posterior canal of the inner ear, BPPV dizziness occurs. Fluid movement occurs due to the crystal rather than head turns, causing the brain to think movement has occurred even though none has happened. The EPLEY maneuver is performed to treat this posterior canal BPPV by trying to get the loose crystal out of the canal. This maneuver is started by turning the head 45 degrees and the body laid back such that the head is extended about 20 to 30 degrees. If BPPV is present, eye twitching called nystagmus will occur. After 30 to 60 seconds, the head is turned 90 degrees to the opposite side and held for another 30 to 60 seconds. The head is then further rotated another 90 degrees, accomplished by having the patient turn onto their side, which is then held for another 30 to 60 seconds. At this point, the head should be turned 45 degrees from the horizontal. When performing this maneuver, another individual can help with these position changes. The maneuver is then completed by having the patient sit up. So what's going on with these position changes? Essentially, the head is moved in such a way to manipulate the crystal to fall towards the canal opening. With each position change, it takes about 30 to 60 seconds for the crystal to settle into the most dependent position in the canal. If turns are made before the crystal has a chance to settle, the crystal may fall back the wrong way and the maneuver will fail. It's also important that the head positions are angled correctly, or else the crystal will not settle to the correct position in the canal and the maneuver will fail. Also, if the position changes are done too slowly, the crystal may not settle quickly enough from lack of momentum and the maneuver will also fail. Once the crystal falls out of the canal, the dizziness should resolve if due to posterior canal BPPV.
And so again, we're trying to get the crystal to fall into that little sac that sits there, and within 24 hours that crystal should be reabsorbed into the body and your symptoms should be pretty much gone.
We're going to take a quick minute. We're going to show you, because there's 2 of us, how quickly, in a sense, that maneuver happens. So I think you can see me, and I'm going to angle this down a little bit so you can actually see where my head goes, so you won't see much of us at the top. Okay.
So again, a couple key things that are important is,
So you can see our head before we go.
a couple things that are important is that when we put you in that 45 degrees of rotation, that your head stays in that position. And then we just have you lay over a pillow and your head is going to be on the table to maintain that roughly 30 degrees of extension. Eyes have to stay open so that we can see if there's nystagmus. Again, if it's to the right, the left, up, down, to tell us which canal we need to actually treat.
Okay, so I'm gonna lower it down so you can see where my head is. And so that way you can kind of get an idea of how this happens. So we'll go this way. Okay.
So her head is just resting on the table. I am watching her eyes. After about 30 to 60 seconds of symptoms being resolved, we can move to the next step. This first piece right here is just the Dix HALLPIKE. This is just the test, but it's the first step of the treatment. So if she's positive and I'm going to treat her, we're going to go to the next step, which is rotating 45 degrees over the opposite shoulder. And I would normally be down here doing this. I'm watching the eyes the entire time to look for some nystagmus still. Again, we would wait 30 to 60 seconds after symptoms subside to go to the next step. So next, she's going to roll to her left side and look down towards the floor. This one's a little bit harder. I can't really see what her eyes are doing. And then the final step, she's going to sit on the edge of the table, looking down towards the floor to that side.
And that's, again,
That's it.
That's where we finish, and we wait there again until the symptoms are gone. All right, so we'll bring you back to where we can sit down and see you guys. And then I think Kate, who has been kind of our moderator in the background, is going to come on in a minute.
Yes.
And we'll answer some questions. We want to show you where we are located. So Crystal and I are located here in Midland. I am at our clinic on Wackerly, and Crystal is at our clinic in the community center. Even though the community center is not open to the public because physical therapy is an essential service, we are able to have access to our clinic inside of the community center. So if you're closer to one of us on either side, we can treat you at either location.
Great. We do have 7 questions.
Wow.
Yeah. So the first one of our attendees has dizziness when they first wake up or when they lay back in their recliner, and otherwise they're okay. So they were wondering if you had an idea of what that might be.
Again, to me, it's positional because it's a certain movement, again, of the head. If you think of the stimulation of those canals, if it's pretty consistent that those movements produce your symptoms, I would maybe lean towards BPPV.
Mm-hmm.
Great. Someone else asked about BPPV also. Is it possible to prevent the crystals from moving?
Oh, no, because the crystals have to move for us to be able to sense motion. So if the crystals didn't move inside of our canals and they didn't stimulate those hair cells, we wouldn't understand our movement, and it wouldn't be how our vestibular system is supposed to function. So sadly, we don't want to prevent them from moving. We do want them to move, but we want them to move in the way that they're supposed to.
We want them to stay attached to the hair cells.
Yes.
I tell people, you think of the otoconia like dead hair cells that just kind of slough off. So some people will have a trauma, like they hit their head or they were in a car accident. That would explain why that crystal kind of got jarred on that side of the head. But as we get older, just like, again, skin cells and just different things, and dehydration, we don't drink as well or stay as active. Those crystals can have a tendency to just kind of slough off. And then that's when it leads to the symptoms.
That's great. You just answered one of the other questions. Somebody asked if hydration affects vertigo.
Yes, it does. It can. So if you're drinking more coffee or you have more caffeine than your water intake, we'll notice the hydration issues can cause an imbalance. We've also, if you have a few fun Friday nights and, you're not intaking water the next day, again, some hydration issues. So we do see that happen.
We just had a new question come in. Somebody said they're still not sure how to tell which side is causing the vertigo.
You won't be able to. That's where we
for
come
us.
in. You can't. And that's why we do all the tests that we do to figure out which side it is.
Great. This one is kind of a two-part question about exercise. They asked, why does exercise seem to eliminate the dizziness, and is yoga a good exercise for habituation?
I guess I'll start. So the yoga, as far as habituation, yoga is just going to help with stretching and staying flexible. It doesn't necessarily stimulate the vestibular system. And in order to strengthen the vestibular system, there are certain exercises that stimulate it. So if you're not doing something that's stimulating the vestibular system itself, you're not necessarily strengthening that system. What was the other part of it? Sorry.
Why does exercise reduce the symptoms? And again, it's because you're stimulating the vestibular system. We're moving, so we're letting our vestibular system know what position we're in, which direction we're going. So all of those activities, without even considering it, you know, you think of it as a muscle. The more you work something, the stronger that becomes.
And you're training your body that it's okay for me to bend over and tie my shoe, or to get something out of the cupboard. It's again, it's what we call the habituation, taking your body to that repetitive stimulus in retraining yourself. It's okay, and I shouldn't feel dizzy.
Yeah, and I guess if you think about it, if vertigo was something you were able to treat with habituation positions, and some of those positions did mimic some of your yoga positions, because different people do yoga at different levels. We have some beginners, we have some advanced. So if you find that a habituation position that works for you is similar to one of your yoga positions that you're comfortable doing and that you can do safely, then it might be a yes to that answer. It might work for you, but for someone else to be in a downward head position for a particular yoga or a backward head position, it might not work for them. So I can't say that yoga would work for everybody.
Okay, great. So we talked about hydration. Somebody else asked what role nutrition plays in controlling vertigo symptoms.
Yeah, same thing. You want to limit your caffeine intake, always have good water intake. It might be that you need to kind of consider what inflammatory foods you're eating, what foods might increase inflammation, especially if it is a vertigo or vestibular issue that's caused by an inflammatory issue with the nerve, or some kind of inner ear infection. All of that could play a heavy part. Also, stress and sleep are two things that can increase or intensify some symptoms of a vestibular issue, especially if it relates to one of the cervicogenic issues that Crystal had mentioned, where we just carry a lot of tension in the neck and shoulders, and if we're real rigid and we're not moving our head and bodies as much anymore, and we're not stimulating that vestibular system, we're going to want to reduce stress, get good sleep, things like that.
Okay, we've got a few questions kind of along these lines that we might want to clarify. People are asking if we can email them the exercises that are shown, but is this something that you would recommend for people to try on their own?
Unfortunately, no. We only, because you wouldn't want to treat the incorrect side, we wouldn't want to send you these exercises not knowing if, one, this is truly your problem, because these are only going to work for positional vertigo candidates. Other vestibular issues would take a different type of treatment. This is just the most common. And also, we wouldn't want to give you the exercises not knowing which side you're supposed to be treating, because that does make a difference.
And also cervical, we have to make sure your vertebral artery is clear, and we have to make sure that you have the proper cervical range of motion to be able to do that testing.
Right.
So to force yourself in those positions, or if you have low back problems, there's different things that we do. So it's one of those, it's not a, cookie cutter that everybody gets the same exercises. It depends on what's triggering your vestibular symptoms.
Great. So to clarify some of the other questions too, you will be able to receive a recorded version of this video, so you'll be able to watch it again, but we don't recommend trying the exercises on your own, the positions.
Right.
So the last question, and then you guys can just go ahead and do a wrap up and share your contact info. Is a physician referral required for BPPV treatment?
Yes. For most insurances, if you'd like to go through your insurance, they will require that a physician is part of your plan of care and that you have contacted and met with your physician to obtain a referral. If you don't prefer to go through your insurance and you would want to pay out of pocket, that is always an option. We do have what's called direct access in the state of Michigan, which does allow us to treat patients without a physician referral if they're not wanting to use their insurance benefits. And it is a flat fee for that. And we would, if you contacted us, we would give you all of the different options over the phone on what works best for you or what might work better for you if it may be better for you to go through your insurance. So a referral is ideal, especially if you're trying to go through your insurance. However, not always necessary.
Great, that's all for questions.
All right. Well, we thank you very much for taking the time out of your day to listen to us speak a little bit about positional vertigo and other vestibular issues. We are here in Midland. So again, our main location is on Wackerly, 2524 West Wackerly, but we are also opening back up, yay, finally, Monday at the community center. So you can see either one of us there, whichever is easiest for you to get to or more convenient for you. And our emails are on the screen. You can email either one of us with any questions or concerns. If you have a contact information you'd like to leave us so we can reach out to you, we'd be more than happy to talk to you about it in the future.
Wonderful. Thanks so much, ladies.
Thank you.
Thanks.